If you've got results and outcomes, then you can have products, not services. No one wants to buy services. They want to buy products. And I know you all went to school, particularly you clinical types in the room, to offer services to people. I want you to offer services. I just want you to package them into products. You got to package them into products. Everybody else is packaging products. The rest of the world is going to products. The hospital has an acute rehab product, has a women's health center product, a bariatric product. You have to have products. You can't just talk about your services. So you have to have outcome data sheets. And outcome data sheets mean, you know, that you can show the results on a web, in a one-pager. People always ask me about brochures. Don't make brochures, make one-page outcome sheets. Sum up the number of people you sent home by disease. There's a great thing. We did this many COPDs, this many heart attacks, this many strokes, this many TPN, this many trachs, this many wound vacs. So, sum them up and show the data. That's a great outcome sheet. That says you have a product on trachs, a product on wounds, a product on stroke, a product on pneumonia. Because see, one day, a company your size in Texas or in Tennessee here or in Virginia, you're going to have to be able to hit a web and it's going to say, what's wrong with you? Not necessarily this way. And it says, well, I've got pneumonia. And then you hit pneumonia and it shows you where you can get pneumonia fixed in one of our centers in the state that we operate in, and it's got all the data. If you're a one-site location, it's even easier. You don't have to come up and roll up all the data for all your sites. You just got your one site in Oakland where you say, this is what we do with this disease. So disease is one roll-up. By keeping them out of higher cost involvement, like what's your readmission data? We told you last year, and it's the same thing this year. It hasn't moved 1 percentage point. In congestive heart failure, heart attack, and pneumonia, congestive heart failure, heart attack, and pneumonia, the 3 areas that the feds are going to punish the hospitals for in 2012, based on 2011 data, there's 22% return to hospital by nursing homes in 30 days in those 3 categories. And we've told every one of the clients in this room, if you can't get down to 11 or 12%, you won't be a partner. You've got to be somewhere close to 6 sigma, meaning 6 standard deviations away from the rest of the public. So if you're going to get it down to 19, yeah, if the rest of the nursing homes are 32, yeah, you can look good. But do you think the hospital's going to live with 19% under the penalty monies forever? They're wanting it down lower than that. You're going to have to get it down to 11 or 12 in those categories. And then as soon as you get those 3 categories, congestive heart failure, heart attack, pneumonia, they're going to add the next one, COPD. That's the next one. Then they're going to add some more. And there's going to be 8 of them before it's all said and done. And they're going to be 90% of all the Medicare discharges from hospitals. And you've got to keep them out of hospitals. And you've got to be able to show that data. You've got to be able to show that data. I'll come back to that in a minute with some partners that can help you. By service satisfaction, you're going to hear a presentation after lunch on that. But you have to be able to show that you have delighted customers, not how many customers you got. I hit your websites and it says how many licensed beds you have. No one cares how many licensed beds you have. They want to know how many satisfied customers you've got. So what's your satisfaction scores? That's why we make you do 72-hour satisfaction surveys at minimum. You should be doing things more frequently than that. We've got to move into some method to get data quickly and use it. You know, I work with clients that are still trying to make sure we know how to calculate average length of stay, or you know, what's the readmission numerator denominator? How is it measured? We got to get beyond that. You know, years ago in staffing issues, we were worried about turnover, and so I had teams working on turnover, and we still do a lot of turnover teams. In fact, there's one of them here today that works on getting rid of staffing problems and agency problems and turnover problems. And you know what? For the first 3 months, they were debating how to measure turnover. You know, it's pretty simple. Carcasses lost. I don't care about the percentage. How many carcasses did we lose? Well, last year we lost 130. Let's see if we can get it down to 128 using expensive consultants. So the point is, then we'll take credit for it. So, but the point is, there's instant ways to go to no huddle offense. And you've got to have partners that can help you do game-changing, market difference stuff immediately, not summed up from 6 weeks ago or 90 days. You need instant stuff if you want to play in today's football game. So I just wanted to tell you about that. So if you move on through the rest of the outcomes, you need marketing that shows results. I already talked about you. You need results-oriented testimonials and heart-filled stories. You know what the number one thing that sells? If you show me data in a story, Mrs. Higgins tells you about the fact that she had this third stage pressure sore and this congestive heart failure condition that had bedridden her for this many months, and she is finally going home today with a no pressure sore, and she is up and walking again today and doing her exercise program, and then she tells a story of unbelievable kindness by a nurse aide or a therapist in that 3-paragraph thing. That is an unbelievable thing that's worth gold on your website, because you've got the two things people want to know: a story and data. A story and data. That's why you want to have service initiatives, so that you can do the right thing for the customers, but you can also capture that you did the right thing. That's why I'm sick and tired of listening that long-term care maims people's life. You guys do millions of acts of kindness a year to other humans that no one else would do if you weren't around. Long-term care is cool. Long-term care is not a bunch of dirtbags. Long-term care is cool. And we got to start collecting that data. And I'm tired of us being on the defense all the time, getting pounded, when we ought to be putting out the stuff to tell people what we do right. And it's up to you, guys. It's up to you. And if your neighbors don't want to do it, then in a caring, loving way, to hell with your neighbors. Steal their customers. And the way you steal their customers is you tell stories from the patient's viewpoint that is data-based and heartfelt. Which leads us to risk sharing and guarantees. And boy, if you want to hear about that, you're going to want to stay tuned for your executives coming out of a conference this afternoon, because I invited Mr. Introne, Jim Introne here, and Jim's not only been a provider, a fair one, but no, a pretty damn good one, but he's also the current Medicaid czar for the state of New York, which is putting a risk-sharing special needs program in place for all the providers in long-term care. Some love it, some are going to be fixing to love it. But the issue is about, can we go to the ability to risk share on the dual eligible Medicare and Medicaid? And I think you're going to find some very innovative ideas there, because Mr. Introne's going to tell you that the organization he was with before they started that took people that they were getting paid by the state $270 a day for Medicaid. Well, a lot of money for a lot of you, but in New York, that's not a lot of money when there's unions and lots of regs and whatever in New York City. And they're now paying themselves with better quality, better outcomes, $400 a day under their own managed care plan for the same customers. You do the math, 400, 270. So I just want to show you, we will have to move to risk sharing in a product, some way or another. You're going to have to risk share with the hospital. You're going to have to risk share with an assisted living. You're going to have to risk share with a home care agency. You're going to have to guarantee some outcomes. I didn't say that you could fix mom's Alzheimer's. I said that you could guarantee that you'll have a great experience here, and we'll do whatever we can with you, and if we can't, we'll fix it. It's that simple. So I need you to ask your neighbors, if you would please, are we talking about our products, or are we talking about our services? Ask your neighbors. If we're going to a horizontal playing field where the government doesn't want any real vertically integrated experts, except if you've got a niche and you'll guarantee it. If you've got a niche and you'll guarantee it, we'll let you play vertically. You can be a specialist in AIDS, a specialist in pediatric children, a specialist in heart surgery at a hospital. You can be a specialist in managed care. We'd love that, because we don't have to date you. We'll let the managed care people date you. But if you want to be a specialist, you can pop out. Other than that, we want a horizontal system. We want to throw the money over the fence, and you all fight for it. And by the way, at the federal level, we don't care if you all make it or not. The issue is, if it's a horizontal system, then what's our option? Our option is to bump out of the middle of the pack by what? outcomes that are different than anybody else that we have as results, and products that we can demonstrate that are different than anybody else. So that's the obvious future, isn't it? If you want to be in the middle of the pack with the government, throwing a little bit of money over the fence, then do what everybody else does. Sit around and do the same old thing. If you want out of the middle of it, I mean, Tim, as an example, his company's based out of Nebraska here, but Tim, over 20 years ago, went into a Medicaid managed care contract specialty with the state of Nebraska for ventilator business. He took a price guarantee with the state for pediatric and adult ventilator business that no one else would do in the area. Many of you have those products. Not that product, but specialty stuff. The point is, how do you break out with a normal nursing home inside of a CCRC or inside of a small town? You break out by having outcomes that is different that you can demonstrate and package in a product that no one else has. You can roll them up in Western New York, and they are different than anybody's. And by the way, we'll stake our reputation on them. This many people are going to get well and go home here. This many people are going to stay out of the hospital. This many people are going to be disease reduced because of our interventions. That's a very powerful thing, which leads us to the point number 5 on your handout. You have to become effective and efficient. And as many of you know who are our clients, we teach a 4-part system. How you admit people leads to how you do the right thing for them, which leads to how you market, which leads to how you sell, which leads to how you admit. ARMS. ARMS is called arms. Put your arms around your revenue. Take up arms against the competitors. Do the stiff arm on the neighbors. Medicare people want one thing. And you know what Medicare people want? It's what every human wants, hope. Medicare people want hope. You know what Alzheimer's people want? Alzheimer's people are not sure what they want, but what their family wants is peace of mind. That's a great product, peace of mind. It's a great product, peace of mind. You know what hospice people want? Pain-free, dignified death. What would general long-term care people like to have? It's called aging in place. That's a fancy term for you're going to live out your life here. But we're going to do it in a nice way for you. By the way, all those products are great products. But you know what trumps every product? Peace of mind, aging in place, pain-free, dignified death, all that? Hope. 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 And that's why Medicare is such a cool product, because Medicare allows you to still have all those other products, aging in place and pain-free, dignified death and peace of mind and disease management and all these other products, but you also get to have hope if you do it the right way. But if you don't do it the right way, it leads to no hope, and then no one wants your outcomes or your products.